Good evening and welcome to this important webinar. This is really the first opportunity to talk about issues paper number 1 of the Scope of Practice Review, which I released yesterday. My name is Mark Cormack, and joining me today is to bring a primary care, very practical primary care perspective to our discussion is Dr. Kerry Ost, as well as being a very busy Canberra GP. Kerry is also President-elect of the ACT, Australian Medical Association. Welcome, Kerry.
Thank you.
And hello and welcome to our Auslan interpreter who is or soon will be joining us. But before I begin, I'd like to acknowledge the Ngunnawal people as the traditional custodians of the land that we're meeting on. Also recognise any other people or families with connection to the lands of the ACT and region. I wish to acknowledge and respect their continuing culture and the contribution they make to the life of this city and this region. I'd also like to acknowledge and welcome any other Aboriginal and Torres Strait Islander people who may be at today's event. Just now to today's webinar. Live captions will be available by pressing the button on the webinar page. Links to any of the resources that I may mention in my update will also be on the webinar page. That is the web page that you use to access this WebEx event. We're very keen to receive your questions and comments, so please start entering them using the Q&A function on the webinar page. First up, I just wanted to make a couple of opening remarks, and then I'll hand over to Kerry to make some comments as well. We're really pleased to announce the release of issues paper number 1. We've been working with you and with a wide range of stakeholders and also with our research partners at the University of Queensland and KPMG. We've drawn together and analysed a lot of evidence collected from submissions, from a literature review and stakeholder consultations from phase 1, which really commenced in September and it run right through until December. And the issues paper that I released yesterday is the result of that analysis. It provides an overview from the evidence that outlines some emerging themes and sets the scene for the next steps of this review. Your contributions have been really invaluable. They've laid the foundation for a very comprehensive understanding of the current landscape. It's important to note as the first paper of 2 that will be developed throughout this process. Issues paper 1 does not draw any conclusions. It doesn't make any recommendations. It really serves as a starting point for further conversations and for further discussions. And we're really seeking your continued engagement to explore some of the quite complex elements in this story that contribute to both the current and future state of health professional scope of practice, most importantly, in the context of multidisciplinary primary health care. The release of issues paper number 1 also signals the start of the second phase of our consultation, phase 2, and we'll go through throughout the course of the webinar the different ways that you can participate and engage. But what I'd like to do now is just to hand over to Kerry. And Kerry, if you could just tell us perhaps a little bit about yourself and also maybe to ask you about what your thoughts are about the responsibilities of GPs and the GP community more broadly and to contribute to broader system change, which is really what we're talking about today. You're on mute, Kerry.
Apparently when you hit the space bar, it doesn't unmute on my computer, so apologies for that. Thank you so much for this opportunity tonight. I'm definitely one of those people who can talk about scope of practice until I'm quite blue in the face, and it's something that I'm quite passionate about. I am a Canberra GP and I do pride myself on having quite a broad scope of practice within my own clinical work. I do what I term cradle to grave medicine. I look after the babies while they're still in mum's tummy, and then all the way through to the grandparents and great-grandparents. And I've met with a lot of GPs recently talking about their own scopes of practice, because we're not a homogenous group and we do have different skills, different areas of interest and different places where we like to work. I think as a group, we are responsible for really stewarding the healthcare system for our patients. And as the leaders of collaborative care, we are used to doing it. We are used to engaging with other GPs, non-GP specialists, with our colleagues in allied health, pharmacy, and mental health right across the spectrum. And I think that's where we really come into our own. One of the things that I think is really important is that we don't look at erosion of scope of general practice as part of this. If we continue to force general practice into more and more subspecialised areas, then we do actually not only lose knowledge and skills, but we lose that opportunity where the benefit of managing someone's viral infection, which we've really started to see a loss of that during the pandemic as we faced infection control issues, is that we lost that chance for the blood pressure check, which leads to palpating the pulse, which tells us about whether or not our patients have AF, which leads to the conversations about mental health, physical health, carer burden, talking about anxiety and finding that tremor. So what I'm looking for out of this process is one that doesn't fragment care, one that allows us to focus on patient safety and considering, markers of clinical risk, like the number of prescribers that are involved in a patient's care significantly increases their risk of an unexpected event, such as a medical mismanagement. If people are seeing lots and lots of different clinicians, they're not getting that quality overview. And it's not enough just to read a discharge summary. We need to make sure that people are putting hands on patients, examining them, and hearing their stories about what's happening with their care. So I want solutions that really look at a broad scope, supported by appropriate funding models, obviously, because we need to work in a system that stops us from burning out with red tape and impossible 6-minute medicine, and really focuses on putting us back in the heart of the system, the respect, the honour that it is to be a GP, and making sure that we actually attract some of those GPs that have left the system because they've burnt out, and help to attract that next generation of doctors who I really hope are going to look after me when I move into my retirement phase at some stage. So I want to see models that place general practice at the heart of patient care, bring in allied health, nursing, pharmacy into that general practice collaborative model so that we can have safe, collaborative, top of scope practice, and focus on not convenience medicine. So convenience food is not good for our patients. Convenience medicine really isn't either. So I really look forward to the discussion and lots of engagement about ideas from people in the community tonight.
Great, thank you very much, Kira. It's fantastic, fantastic perspective, and I think we'll certainly return to some of those comments as we work our way through. So what I'd like to do now is spend probably the next 15 to 20 minutes just with a brief presentation to talk you through what the paper is aiming to elicit, and we'll just have a presentation to share. And then once we're through that, we've got the balance of this session to take some questions and comments from all of you. So we might just move to the next slide, please. So what I put up on this slide is essentially it's really the table of contents from issues paper number 1, which, as I said, is available now. Many of you may have seen that, and I'll just step you through that today. The main elements which we want to talk about are section 4, which is the emerging themes. The next slide, please. So the background to the scope of practice review: in July 22, Strengthening Medicare Task Force was commenced. The report was released in December of 2022. In April of last year, National Cabinet endorsed the task force recommendations, and part of that was addressed in the 23-24 federal budget, where a number of budget measures were announced, including the review that we're talking about today. And it's really important to keep strengthening Medicare Task Force report at the heart of all our considerations today. It's a very critical piece of policy work, and the work that we're undertaking in this review process is meant to articulate with and support and in many ways implement the intent of that important piece of policy. So we've been on a journey of this review since the beginning of September last year. I'll just step you through the flight path. There's 4 phases. The first phase was to set the project up. A first round of public submissions and consultations that closed in October, and we drew that to a close pretty much in December, and then prepared for phase 2, which is where we are now. Phase 2 runs through until March. The starting point is really yesterday, in that we released issues paper number 1, and that's what we're talking about today. It'll be subject to very extensive consultation, and I'll talk about that in a minute. When this phase is concluded, we'll begin phase 3, where we'll draw together a second issues paper, and that issues paper will start to shape up and put a little bit more detail around the barriers that are being experienced, and also some of the potential policy solutions to that. There will be a third round of public consultation that will lead up to the 4th phase. In phase 4, we will prepare and release a draft final report and implementation plan, and from that there will be a 4th and final round of consultation before the report and the implementation plan are delivered to the Minister for Health and Aged Care. We also have an expert advisory committee that is providing guidance, insight and advice at key steps throughout this process. So what's the purpose of issues paper number 1? It's really about providing an overview of the evidence that we've collected to date through the literature review, the submissions and consultations, and it will outline what we see as some of the emerging themes from this evidence. These themes require further exploration, and that's really what the purpose of issues paper number 1 is, to as a basis for consultation, and then it'll outline and describe the next steps in this review. Broadly, what we can say at this stage from the evidence that we've gathered, 2 key overarching findings. First up, enabling health professionals to work to full scope of practice supports a stronger primary healthcare system, with that earlier emphasis I mentioned on the importance of a multidisciplinary primary healthcare team. The second key finding, and we're going to go through this in quite a bit of detail today, there are a range of barriers that are currently preventing the primary healthcare workforce from working at its full scope of practice. And finally, the benefits that we think will emerge from this. There's very strong evidence of improved consumer access to care, the consumer experience of care, and health outcomes when health professionals are enabled and supported to work to full scope of practice. In the primary healthcare setting, health professionals and teams working to their full scope also reduces the workload for the acute care sector, which is in part what the primary healthcare system is about. Importantly, it increases health professional utilisation and retention, and that's a system-wide problem across our workforce, and also creates efficiencies at a system level. So that's what the evidence is telling us. That's what the literature is saying to us about this. Next slide, please. So this is how we framed the emerging themes. So we've identified 5. One is legislation and regulation, employer practices and settings, education and training, funding policy and technology. They're the 5 broad themes. Each of these 5 themes is presented in the issues paper, and it follows the structure of the context, the challenges, opportunities for improvement and benefits should these barriers be overcome. And it's also important to note, and I'll try to stress this as we go through, the barriers and enablers within any theme may overlap with those in other themes. So there is an interdependency, there's interaction, and the impact of policy solutions across the themes needs to be carefully explored through this and the following phases of the review. Let's go to the first emerging theme. Legislation and regulation. So we're talking about key policy levers for scope of practice, inconsistent regulatory approaches across health professions, including named professions in legislation and regulation, and lengthy and inconsistent endorsement processes have certainly been identified as well-known barriers to health professionals working to their full scope. We've identified in the paper a number of potential enablers that could be matters for further exploration and consideration, and we're very keen to get your views and guidance on this. One obvious one, and one that comes up every time we talk, is harmonising drugs and poisons legislation. The second potential enabler is starting to look at introducing risk-based and activity-based regulatory processes to complement the existing arrangements of named professions. There appears to be some scope and appetite for streamlining endorsement processes, and also reviewing the authorising environments for the self-regulated professions and the unregulated workforces, which are becoming an increasingly important part of the primary healthcare system. The benefits, should these matters be satisfactorily addressed: 1, better consumer access and continuity of care. Secondly, improved workforce satisfaction and retention, and also a building of interprofessional trust and understanding. Some of the risks, of course, in activities in this areas, if they're not effectively implemented, that can be due to employer-level practices or funding policy arrangements, which may not necessarily be aligned with or work in the same direction as legislation and regulation changes. The second area that's outlined in the issues paper is that of employer practices and settings. Enabling and authorising environments at the service level and across multi-service care teams are critical for health professionals being able to work to their full scope of practice. And the barriers here include inconsistent authorisation to perform particular activities that may be the same activities, but the authorising varies across settings. In some instances, we've identified gaps in employer recognition of endorsements and specialised skills, and in others, insufficient employer support for multidisciplinary care teams. And as I mentioned before, these barriers interact with other system-wide barriers and enablers. So we've identified some potential enablers. The first one is to look at establishing more consistent approaches to the recognition of additional and specialised qualifications and competencies across settings. And by that, I mean we have a very good system through the National Registration and Accreditation Scheme already. It's very clear what people are trained and qualified and recognised to do, but that does not always translate into custom and practice at the workplace. Secondly, looking at establishing models of multidisciplinary care for target patient groups, and strengthening support for health professionals to work together across different employer groups. And thirdly, reviewing and strengthening clinical governance mechanisms in the primary healthcare system. And certainly we see quite a difference between the depth and level of sophistication of practical clinical governance mechanisms in the primary healthcare system compared to the acute and hospital system, in some cases for many good reasons because of the different risk profile. But we think there is a case to build stronger support for primary healthcare orientated clinical governance mechanisms. Benefits: improve consumer access, improve capacity to work effectively as multidisciplinary care teams, improved workforce satisfaction and retention. This is a common theme across all of these 5 theme areas, and also improved accountability, quality and safety. There's a number of risks here. One is that introducing a new focused emphasis on multidisciplinary care can simply result in a different or a new silo rather than working in a truly coordinated way. And we'll go to the next slide, please. The third theme is that of education and training. The primary healthcare system's got a proliferation of education and training requirements for competencies across health professions, and they differ depending upon how a profession is regulated. At the professional entry level, they're very consistent across the 16 nationally regulated professions, but our consultation findings indicate that access to continuing professional development training, particularly for new and additional skills and for expanded scope, is not consistently supported in practice. And the training requirements for some similar or common competencies apply inconsistently across professions in some cases. So, some potential enablers: establishing greater system clarity about the requirements of profession entry learning across the professions. Secondly, establishing a nationally consistent approach in promoting and implementing common interprofessional competencies, and there are some examples of those already, which we think could be built upon. Promoting and strengthening multi-professional learning, particularly in the context of multidisciplinary teamwork, and ensuring ongoing education and training is accessible. The benefits: improve consumer outcomes, again, workforce satisfaction and retention, and building that important interprofessional trust and multidisciplinary care delivery skills. Some of the risks here are that the recognition of training competencies and scope of practice sometimes relies on factors outside of the individual health professional's control, e.g. employer practices, which is the previous theme, and interprofessional trust. Next slide, please. Funding policy. Funding policy and payment models underpinning the primary healthcare system have got wide-ranging impacts on the ability of health professionals to work to their full scope of practice. There are concerns that the existing fee-for-service funding mechanisms is not flexible or broad enough to effectively support long-term care relationships, continuity of care, or multidisciplinary care. If there isn't a payment mechanism available to support true coordination and multidisciplinary care, then it's unlikely that that model of care will proliferate. So some potential enablers that we've outlined in the issues paper, looking at different funding and payment types in addition to fee-for-service. So block funding, bundled payment and blended funding to deliver care flexibly, and these are also highlighted as key recommendations in the Strengthening Medicare Task Force report. Funding and payment types that incentivise working as multidisciplinary care teams as opposed to single discipline practice, enabling, in some instances, non-medical professionals to make direct referrals for additional consultations. And also there is some call for funding episodes of care that are similar, effectively similar, regardless of profession, e.g. a single MBS rate for a similar activity. The benefits are improved continuity of care and collaborative care delivery, reduced time and cost burden for consumers along the care pathway, reduced burden on the GP workforce, and more effective chronic illness management. Some of the risks associated whenever you change funding policy or the type of payment, there can always be the risk of unintended incentives or disincentives for certain types of care delivery. There's the risk of poor team cohesion if there's seen to be too much scope overlap or perceived role threat. And also these things are very heavily dependent upon good quality digital infrastructure, but also adoption of that digital infrastructure across the system. And the final theme that's outlined in the issues paper is that of technology. So robust digital health infrastructure can enable consumers and health professionals to access and share information and to work together more collaboratively and equitably by ensuring all health professionals have got visibility over the same information as they need to. Modernising data and digital technology is a key government reform direction. We have just, in the last week or so, seen the release of the blueprint and the action plan, but there are clearly key gaps in the current primary care IT systems, infrastructure and adoption. So potential enablers, a much stronger focus on establishing access to real-time patient information with consent across the multidisciplinary care team when it's needed. Introducing or building on platforms for secure messaging and digital referrals, and picking up on Kerry's point, a late discharge summary is generally insufficient for this sort of work. Greater use of decision support software, and also there might be a case, particularly as more health professionals work to their full scope of practice, some form of mandated participation in multidisciplinary care teams for primary care providers to build that system-wide cohesion. The benefits are improved care coordination and continuity of care, improved quality and safety of care, and the evidence certainly strongly supports health professionals working as part of multidisciplinary care teams, their full scope of practice with appropriate clinical governance mechanisms in place does improve the quality and safety of healthcare. Reduce time and cost burden for consumers, and also potentially reduce cost burden on the whole health system. And some of the risks we need to identify and talk about are the potential risk of inconsistent adoption across professions and settings. We certainly see, very much a two-speed approach where specialists and many of the allied health professions are a fair way behind where modern general practice is in terms of having good quality decision support and practice tools, and also an overarching risk, whether it's associated with full scope of practice or the broader digital health agenda. Any collection of sensitive personal data is associated with known and ongoing risks of data breaches, and we've certainly seen a number of those in recent months. So I'll just go to the final slide now, just to give you a sense of what's coming up. So as of last night, we opened up our online public submission process, and that'll be up and running up to the 8th of March 2024. We're also welcoming your own individual submissions as well, provided they address the questions within the issues paper. We also have a very significant program of stakeholder workshops and discussions on the themes. They'll be running across the country throughout February. Once we've concluded phase 2, I will begin to prepare phase 3, and phase 3 starts to shape some of the learnings, some of the insights and perspectives and comments on the themes that we're sharing in issues paper number 1. We'll shape that up into some potential more detailed policy solutions and implementation pathways. There'll be a round of consultation on issues paper number 2. Then phase 4 is the draft final report and implementation plan, which we'll put out for public consultation in July, ahead of a final report and implementation plan submitted to the Minister for Health and Aged Care in October this year. So that concludes the formalities of this presentation, and I thank you for your patience in listening to that. And it is really intended to give you a preview of the 33 pages that we have in the issues paper. But it's an insufficient executive summary. I'd encourage you to read the paper and in particular have a look at the questions that we're seeking to get some input on. So before I open up for broader questions and comments, I'd now like to hand over to Dr. Kerry Ost, perhaps for some initial reflections, comments, questions on issues paper number 1.
Thank you very much. So, like most people on the event tonight, this is my first contact. I think I saw it about 15 minutes before we started tonight, so I started to have a flick through. I think it's great that it covers such a broad range of where scope of practice comes in, and I was writing down some little notes as we went through and thinking about what it actually means to define a scope of practice for different professions. And I think it really is important that we start to articulate what professional scope of practice can be and recognise that just as within general practice, we all have different scopes, and there's a great question about what is the full scope of a general practitioner on the board, and the answer is going to be that it is different for all of us. We have a really great kind of safety net for patients in that we have our medical indemnity insurance, and we, as part of that, are required to state that we are going to operate within our scope of practice and that we're going to make sure that we have appropriate education and skills to stay in that space. So for someone like me, I do a little bit of skin cancer medicine. I am quite comfortable with removing small lesions from most parts of the body, but my training requires me to recognise where something's outside of my scope and refer that on appropriately. So I think one of the great things about medicine is that we do have that really, really strong basis of saying this is where my scope of practice is limited. I think outside of that, we need to make sure that we are not going down a path of over-certification where suddenly if I want to do a mental health care plan, I have to do another course. I am incredibly comfortable with ADHD management and do the vast majority of it for my patients, and that's a space where I'd really like to see us have some national consistency so that we can provide a more efficient process for our patients. So I guess really, which is a funny thing coming from someone from the AMA, is that I want this process to be led by safety and efficiency and not politics. So exactly as you say, nationally consistent standards, utilising the respected bodies like the TGA to say, this is who should be prescribing this schedule of drugs, because we have determined that that's the safest outcome for patients. And really making sure that we have genuine review to make sure that it is the most efficient and most effective use of resources. So we know some areas where our health system has been fragmented, a review has not been done of that service since 2013. We don't actually know whether or not a particular service provision is providing an effective service for patients or whether it's just costing more because they're seeing multiple health practitioners all at the same time. And finally, I think always coming back to the heart of diagnostic medicine and clinical evaluation, not being a skill that you can learn on a 6-week course. It is something that doctors train before medical school, during medical school, and then during our specialty training. And we should never lose sight of, it's very easy to think everything's a UTI if that's all you're treating. And we need to be thinking about broader things like STI, malignancy, autoimmune conditions, rather than just treating with antibiotics.
Gary, thanks very much. We've got a whole pile of questions, but do you mind if I just comment on some of those?
Definitely.
So thank you very much. Look, I think your opening comment around the importance of defining professional scope of practice is a really important one. We've got some definitions in the document, but I think having a broader conversation about what that means, and in the Australian context, it's really how scope is regulated, not only how it is defined, but also how is it trained, how health professionals equipped to work to that scope, and what are the education and training arrangements. So I think that's absolutely a critical point that you raised there. I think in many ways the scope of GPs is, and you may not feel this at times, but is the envy of many of the health professions, because it is so broad, potentially so broad, sometimes maybe too broad. But if you're in a bigger practice or you've got different arrangements in place, having that breadth of scope and the I guess the regulatory freedom to be able to go in deep into different practice areas and specialty areas, I think is a wonderful attribute of the primary healthcare system, and it's one that we really, anything that comes out of this, you'd really want to be strengthening that. Also, you raised the point of the risk of over-certification, and that did come up quite a lot. Again, it's not that much of a problem for the medical professions, or I should say for general practice, as it is for some of the others, where the other professions where, and we've identified this in the paper, where so there's this balance to be struck between if you're wanting somebody to work at a higher scope, then you need to have the proper accreditation of the training that gives you the right to do that. But at the same time, if you impose that burden on every single aspect of scope, then you're losing flexibility in the healthcare system workforce, and I think that's really important. And the final one, which is a bit of a, we could take on as a bit of a mission here, really, is this should be led by safety and it should be led by efficiency, and I think they're really great points. So thank you for making those. So I'm just going to work through the Q&A box. And some of them are comments and some of the questions, but the first one is, I feel that funding policy really should be your number one point here. Look, thanks for that. What we're trying to stress is that there are at least 5 broad themes of comments. Funding policy is really, really important. In a system, if you get what you pay for, to put it really simply, and if you value care coordination, if you value multidisciplinary teamwork, then clearly there must be some kind of funding and payment policy that enables that to happen. But what I would say is that funding policy needs to be seen in the context of the other areas that we've talked about. In of itself, it's likely to be insufficient to resolve the issues we're focusing on. The second question I've got, is how are we looking at the encroachment of pharmacists into the GP scope of practice? Would it be a potential to let GP clinics have a full service in which they can sell vitamins, probiotics, shampoo and GP services? I'm not aware of what restrictions there would be on that. However, I'm sure you've probably got other more important things to do in your practice time than those sorts of things. But I think this issue of encroachment is really at the heart of the question here. There are, within our system, and as you know, the National Registration and Accreditation System more specifically regulates and protects title than it does protect scope. Scope is not protected under the scope of individual professions is not hardwired under the national scheme, although it certainly is in many ways in practice. So I think there's a case to look at common competencies, and indeed there are already common competencies across the professional groups. There's some work being led by ARPA and the national boards in terms of cultural safety as a cross-disciplinary common competency. So we're really keen to get your further thoughts on this issue of common or overlapping scope as opposed to activities that should or could only be the domain of a particular named profession, and that's one of the I think one of the more contentious issues particularly in the regulation and legislation space. So thank you for that one. A bit clumsy with my mouse skills here. Here's an easy one. Will we be able to see paper behind tonight's presentation? And we'll be able to access a recording of the presentation. I think yes, that my team here is saying that's fine. That the actual paper is already up on the website. We can make the slides available, and you can lull yourself to sleep with this recording of me for as long as you wish. The next question, this comes from Liz Miles. Hi, Liz. How will the burden of GPs be reduced? Will all outpatient consultations now be complex and chronic? Look, I think that's a really good question. I think there's a risk that, and we do mention it, it certainly came up in the first round, that if there's a sort of a wholesale transfer of tasks of lower complexity from one profession to another, and that certainly doesn't appear to be what's been suggested, then that leaves GPs in particular with a very sort of, with themselves working at their full scope, if you like, all the time. And I think, Kerry's opening point about the importance of some of those simple episodic interactions that GPs have that enable you to, what may be a simple thing such as taking a blood pressure or getting a regular immunisation or whatever, but they provide an opportunity for engagement on a far more complex issue. So I think the case for reducing the burden on GPs we need to explore through this consultation exercise. And I don't really have a firm view, but there's certainly some evidence that if you've got a cohesive multidisciplinary team where you've got interprofessional trust, you understand what each other can do, then you can get a greater complementarity that can enable some of the more tiresome and lower value work that maybe doesn't even require a GP or a health professional to do it, could be minimised. But I think that's certainly an area that we need to explore a little bit further. So thank you for that question, Liz.
May I just
jump in?
Yeah,
Yes, jump in.
I just also like to add something to that, is that as part of delegation, there's always still got to be a closed loop communication. So it's not enough just to delegate those, let's call them simpler tasks, to other people, without making sure that we also have funding arrangements to ensure that the person at the centre of the care still has time to actually get their head across everything that's going on. So at the moment, our funding models are very much based on the patient sitting in front of you. And if we further fragment things and we're reading more letters and that it's not just enough to, when I get a letter from a walk-in clinic, I have to look at the clinical assessment that's happened, satisfy myself that they don't need further follow-up and then recall them or not, update all of their files, and all of this is unseen work that happens within general practice. So I think we need to make sure that that's not lost in these discussions about how to expand the scope of others and decrease the burden on GPs, because we may actually just increase our unpaid work burden.
Yeah, thanks very much for that, Kerry. I've got another one here which I'll read out, but I might ask you to comment on this one first, if you don't mind. This is from Louise Stone. Hi, Louise, a colleague from ANU. Could you please comment on governance? At the moment, there seems to be a difference between the governance of GPs and the governance of others. Now there is extended scope for other professionals. Will they need extended governance? I'm presuming it's clinical governance we're talking about there. Would you like to comment on that one, Kerry?
I think I'm not sure if I'm going to be on the right track, but there's very little transparency in regards to the clinical governance structures that are in place for particularly some of the scope of practice trials that have happened around the country. So really understanding what the patient outcomes are, capturing adverse outcomes. And one of the things that I think is quite interesting is understanding or gauging what patients understand about the clinical skills and training of the various health professionals that they engage with. And I know that in the past, there's been statements about patients understanding the difference between, seeing a naturopath and seeing a medical doctor, and that they understand that there's different training and therefore different evidence bases. But my experience with patients is that that is not actually always the case. There is often an assumption that if somebody is allowed to do something under current legislation, that therefore they have an equivalent level of training and experience. And this comes back again to those skills in diagnosis, evaluation, and overall patient care. So I do think that often GPs are held to different clinical governance standards that are not necessarily reciprocated throughout the health system. And I think one of the wonderful things that could come out of this scope of practice review is to highlight where some of those gaps are and bring everybody up to the same standard.
Thanks for that, Kerry. And Louise, just my comments on this one. We actually specifically mentioned this in the issues paper in many ways for the reasons that one of the reasons that Kerry just outlined. If there is a case for the putting in place supports to expand multidisciplinary teamwork in primary healthcare, and everybody seems to agree that's a good idea. If we also follow the recommendations from the Strengthening Medicare Task Force report that we should be in a system where everybody is working to their full scope of practice, then if that is different to what we have now, then we need to have in place mechanisms for managing risks that are proportionate to that change in the way care is delivered. And certainly in the hospital systems, and they've got a very different risk profile, but they have, over the decades, really built up very, very sophisticated clinical risk management and clinical governance mechanisms to support multidisciplinary care and to support health professionals. So that's the reason why we put it in there, and I'm really glad that you picked up on it, and we're very keen to have have a lot more discussion on that, because I think that's what the public is looking for. They don't want a risky healthcare system. And if we can strengthen governance arrangements to mitigate that, all about. I've just been given the 10 minutes hand wave. So
could I raise one question that I think is really interesting to explore? And it's one from you, and I'm having a little bit of trouble finding it at the moment, but it was essentially about, here we go. Dr. Ewan McPhee, I believe that GPs and others need to be supported to make the best of their connections to benefit patients. For example, funding specialists to respond to clinical questions would assist me in triaging whether managing the patient is in my scope or not, especially as a GP in a rural or remote area. And I'd really just like to throw my support behind this, because as our hospital and non-GP specialist colleagues have become increasingly under pressure, our capacity to access that timely phone advice while we've got the patient sitting in front of us is getting more and more difficult. Will that be included within this scope of practice review?
We're certainly looking at that in the context of supports for multidisciplinary healthcare, but also there's a theme on technology and digital, and I think that we took a few steps forward during the COVID pandemic with use of some aspects of digital and virtual care, and maybe we should look at this opportunity to explore that greater interconnectedness and support that particularly rural and remote GPs such as Ewan and I, Ewan, have been slugging away at for decades. And it would seem to me exploring digital solutions that support GPs and other health professionals, particularly in rural and remote areas, to know the limits of their scope and to be supported to work at their full scope of practice through modern kind of funded digital consultation mechanism. I think so. Yeah, it's a really terrific idea.
I'm not sure I should break the news to you that I haven't been able to access any of my patients' My Health records for the last month across multiple clinics. So I think we have a little bit of a way to go with getting the technology right. But I'm glad there's a focus on it, because technology has the capacity to increase our efficiency. We just need to get it right.
Yeah, certainly. We've got a question from Carolyn Johnson. Where can we find more about the depth and breadth and rigour of the literature review mentioned in paper 1 that has provided the evidence? Thank you for that question. We're just in the stages of assembling and pulling that together into a more comprehensive paper. And our colleagues at the University of Queensland and supported by KPMG have been asked to undertake that work. We've been able to incorporate the initial phase of that evidence review into issues paper number 1, but we envisage having a much more comprehensive paper available in the not too distant future, and we'll certainly make that available as soon as it's completed. But it's certainly been an integral part of the preparation of issues paper number 1. When we get to issues paper number 2, it is very much the sort of evidence bedrock that will be important for making sensible recommendations for policy change. Thank you very much for that, Caroline. Just checking another one. Okay, this one's from Kathy. The emphasis on employer makes me question how much understanding there is of Australian general practice. Whilst many GPs are employees, the details discussed in the paper don't seem to match reality for the GP contractor employee in the system. Good comment, I think we probably will need to explore that a little bit more in our consultations. It was really, I guess the heading is employer practices and settings. So it's a combination of the nature of the enterprise or the health service in which health professionals work, and that can be GPs and of course non-medical health professionals as well. And it wasn't meant to be exclusive of or divorced from different forms of employment such as salaried, sessional or contracted. So thanks for raising that, and that's an important point to comment on. I'm getting the wrap up here. So what I think I might do is I might just throw to Kerry and just see if you have any final observations and or exhortations for this stage of the review.
I think I'd just like to come back to it should always be about patient safety and the most appropriate health professional working, to really recognise that I've mentioned that general practice is not homogenous in terms of where scope of practice lies, but the same thing applies to our exceptional nursing workforce. I know one of our nurses is incredibly comfortable with a very broad scope of practice, and another one less so, and likes to stay within a particular boundary. So we need to make sure that we enable people to have their own career journeys as part of all this. And I really want to reinforce the importance of effective evaluation. So I don't want us to see us go down the assistance pathway of the US and the UK, where what's seen as a cost-effective, cheaper option for patient care gradually erodes the basic resources of general practice in their countries, because it's very, very hard to come back to a strong general practice once you've lost all of your GPs. So I think there's a lot of opportunity for us to really harness everything that GPs can do as part of this. And I really hope that everyone engages in providing feedback to your team so that you can capture all that we do. And feel free to come and visit us in our clinics, because I'm sure we'd love to have you.
Thank you very much, Kerry. Thanks for that summary, and thanks for your incredibly sharp and focused insights this evening. It's been really, really helpful. I'd just like to wrap up this session by saying thank you. This has been a particularly well-attended webinar, and I know you've all got incredibly busy work and home lives to attend to, and I just want to thank you for setting aside the time for your input today. This is the beginning of a series of conversations. We have learned so much through practical insights from the clinic face and from the different professional craft groups throughout this process. We're really looking forward to your continued engagement. We'll try to make it as easy as possible with the digital means, submissions. There'll be some face-to-face sessions, and also, we'll have some targeted discussions with a number of the representative groups. But thank you very much for the opportunity to share this with you. I commend the paper to you. Really looking forward to your input and response. And have a great evening, and I look forward to working with you as the review continues. Thank you very much.